Good evening, this is Brian Cavanaugh on behalf of my co-host Kaylee Doak. Welcome to tonight's presentation of the Virtual Visiting Professor Network. But first, a quick word from Tom Eichler and Nina Taylor.
Hello, everyone. I'm delighted to invite you to the 62nd Astro Annual Meeting. Now, I had hoped to welcome you all face-to-face in Miami Beach with handshakes and hugs, but, well, you know the story.
In late April, Astro made the decision to re-engineer the live meeting to create an enhanced virtual educational experience. But this is no ordinary online meeting. We are looking forward to hosting an immersive, interactive, and innovative meeting in October.
The theme for this year's meeting, Global Oncology, Radiation Therapy in a Changing World, presents us with a unique opportunity at a moment in time unlike any other. We'll examine the unique and diverse challenges of cancer management in low and middle-income countries. Also, the hurdles facing patients living in rural America and the inner city, and how current scientific advances can be applied in these often difficult environments, all with the COVID-19 pandemic as a backdrop.
Attendees will enter the Astro 2020 annual meeting through the virtual doors of the Miami Convention Center. Well, you will notice our show look and advertising from our amazing ambassadors and exhibitors. Also from the lobby, you can access meeting rooms to attend scientific and education sessions, as well as networking lounges and the interactive exhibit hall.
This year's Astro Annual Meeting is a unique opportunity unlike any other. Don't miss it.
Tonight's edition of the Virtual Visiting Professor Network is a very special edition in which the RedJournal podcast will be hosted by Drs. Anthony Zietman and Sue Yom. Their guests will be Dr. Paul Volberding and Dr. Daphne Haas-Kogan. The title is Reflections on Pandemics, Scientific and Personal Journeys from HIV to COVID-19. I hope you enjoy it.
What a pleasure it is for the RedJournal to join forces tonight with the Virtual Visiting Professor Network. And I really want to thank Brian Cavanaugh and Kaylee Doak for just making this possible. As many of you probably know, the RedJournal puts out a monthly podcast, and it's usually the editor-in-chief's flight of random ideas. And it's okay, but on special occasions, and with huge guidance from my deputy editor, Sue Yom, we like to up the ante. And today is one of these occasions. We've got a special edition coming out very shortly that features many articles, many of your articles, describing the ways that this pandemic has changed our specialty. And a crisis such as this forces rapid change in medicine. And though we don't yet know what its final mark will be, we are certainly living through some kind of cultural revolution. But this isn't the first such virally induced revolution in medicine. And two contributors to the RedJournal's special edition wrote of their experiences during a previous pandemic, that of HIV and its associated disease AIDS, which broke in the early 1980s. It left a deep imprint on the way we practice medicine, the way we view patients, and the way we connect medical issues with larger issues in society. And for those of us who trained in the 1980s, now I'm one, it was the formative medical experience of our generation. And we're very aware that a lot of you watching this vodcast have very recently been through a comparable experience. I mean, you've lost training time. You've been called to practice medicine outside your areas of interest and comfort. You've seen suffering on a huge scale, and it's not over yet. Our rather grand goal tonight is to spend the next hour or so in conversation describing the previous pandemic and its aftermath to try and help you process and make sense of what you've all been through yourselves. So to join us today, Sue Yom and I have invited two important colleagues who were witness to and active participants in the early years of the AIDS crisis. One was in leadership and saw the crisis and drove the medicine from above. And the other was very much like many of you recently with COVID. She saw the crisis from below, the intern's view, not driving events, but actually being pulled along by them. And the first of our guests is Dr. Paul Volberding from UCSF, who in 1983 formed the first inpatient ward for HIV patients, was deeply involved in clinical trials of antiretrovirals, went on to edit AIDS journals, head guidelines panels, and lead the UCSF AIDS Research Institute. And our second guest, well known to you, is Dr. Daphne Haas-Kogan. chair of radiation oncology at the Brigham Dana-Farber in Boston, a big player in the world of pediatric cancer, but someone whose very being was, as a junior doctor, forged in the heat of HIV. So welcome, Daphne, and welcome, Paul.
Great to be here.
We're incredibly grateful to have you with us to share the lessons of AIDS in an age of COVID. And also welcome to Sue Yom, whose energy makes this happen. So Sue, do you want to lead us off tonight?
I would love to do that. And I want to especially thank Dr. Volberding, who wrote a lovely editorial for us, which actually inspired the topic for this vodcast tonight. And one of the things that he focused on was comparing and contrasting some of the characteristics of the HIV and SARS-CoV-2 virus. And I thought, Dr. Volberding, for those of those of us who haven't had a chance to read that draft or that article yet, I thought maybe you could go over some of the contours of that comparison, because it is a very interesting comparison of how these viruses are so different in their nature and yet share some similarities in terms of their transmission, what they've done to our society, how our reactions have been.
Sure. Thanks, Sue. And it's and Tony, and it's great to be here. And I look forward to the discussion that we're having. So in the article, I talk about, if I were being cute, I guess I'd call it a tale of two viruses or something, but I didn't. But it's important, I think, to try to remember, and for probably a lot of people on the call today, you weren't around to remember it personally, what it was like to have a new virus appear very suddenly in our midst. HIV appeared seemingly out of the blue, although we now know it's been around quite a while. What it was like to respond, what it was like to take care of patients when we had fears about our own health. And obviously the comparison to COVID is on some levels pretty straightforward. Healthcare workers are at risk for getting sick from and even dying from this new infection. The viruses are very different, though, in some ways, and very interesting in the ways they're different. HIV is actually quite difficult to transmit, and as a result, the risk for actual infection we now know was pretty well restricted to certain parts of the population. And the disease that it caused appeared only after a long period where people could transmit the infection without knowing it. Now with COVID, obviously, we have a virus with SARS-CoV-2 that is amazingly transmissible, and we've seen it now sweep the entire planet. In contrast to HIV, everyone is at risk. Everyone in the world is at risk for this virus. And even though the mortality rate is far lower than HIV, which killed essentially everyone until we developed treatments, this is a virus that kills only a small fraction. But again, the effect on the population is so huge. I thought things went fast with HIV, that our knowledge increased rapidly. This is HIV on steroids, I guess you'd say. The knowledge we're getting almost daily about COVID infection is really astounding. We still are really at risk, though, and I think we've all seen how it's changed our society. People are at home with kids that can't go to school, and so I think. I hope we can talk more about that, because I think a lot of healthcare professionals are really struggling. And I've become concerned, especially about some of our earlier career stage women faculty members who are probably disproportionately feeling the pressure. But I look forward to this discussion, and I hope we can make it fun too.
Oh yeah, we're going to definitely lean into some of those issues quite heavily a little later on. But we like to almost go back to the beginning of AIDS, so the early 1980s. So most of our audience are medical students and residents, and most weren't alive during the early days. So can you describe what it was like being a young doctor, the early 80s, on the medical floors when young men, with unusual cancers and bizarre opportunistic infections just began to appear in larger and larger numbers on the floors?
Sure. I had just finished my oncology training and had taken a clinical job in July 1981. And my first patient that first day on rounds was a 22-year-old man with Kaposi sarcoma. I knew nothing about Kaposi sarcoma. And we really didn't know the gay community very well either. Medicine, even in San Francisco, was kind of very separated from the gay community. But we learned quickly that the care of these patients that were so sick and often without what we would consider regular families required that we learn kind of where they're from and what other organizations, what other people could help us in the care. As we all know, oncology and HIV and AIDS as an extension is largely an outpatient care, and so we learned a lot. And I learned myself about palliative care, really, in a sense, in the care of these patients.
Were you afraid, Dr. Volberding? When
Yeah.
this was happening?
Yeah, I was. That we pretty soon, by the end of 1982, decided that it really was a virus. We had evidence for that. We didn't have the virus yet, so we had a new disease. It was horrible. People were afraid. People were dying. We thought it was a virus, but we didn't know what kind. We didn't know how it was transmitted. We didn't know the incubation period. And none of us were wearing PPE at the time. It was considered crazy to wear a glove if you're doing an art line or almost any other procedure. And so there was a period of time, and my wife was also an internist here at UCSF, and she was taking care of AIDS patients. And we were having our family at the time. Our kids were born in 81, 84, and 87. So we were really afraid. And when the first HIV test came out in the middle of 1985, I was one of the first to volunteer to be tested because I was really concerned. Fortunately, negative, and given that, we could really then say vigorously that this wasn't a casually transmitted infection. If we weren't infected, the general public didn't have to worry.
I mean, a lot of our residents were we were all very worried about PPE in the early days of COVID. What were you doing to protect yourself? I seem to remember we occasionally put gloves on.
Yeah, that was all.
Arterial stab, and that was it.
That was all. And, I rarely wore a mask, certainly didn't wear face shields. I don't think they were around. No, we didn't wear gloves when we examined patients. Obviously, if there was, soilage, we did, but not beyond that. So gloves were about it.
And then it strikes me it's kind of similar because when the COVID pandemic was declared, we also had very little knowledge of the virus, sort of like you're describing. And I think there was a period when people were really pretty afraid. But it's interesting to me how quickly we gained some level of comfort, I believe, in the COVID-19 pandemic. And do you think that, I'm curious about that, because it seems like with HIV, maybe just the science wasn't as fast, or it wasn't as developed, or maybe the information transmission wasn't as quick, but it seems like with COVID-19, we found out a lot about the virus pretty quickly, identified these protective measures, and the medical community has, I think, some level of comfort that they understand the virus, at least what basic measures they need. And so do you feel like that uncertainty was less here and helped us in a different way than HIV?
Well, things went so fast with COVID, and that there was a brief period where we weren't sure that there was respiratory transmission, but I think it quickly became clear that there was. And there's a little bit of hesitation about recommending masks, but again, a very brief period. And now I think we all agree that masks are probably one of the most essential parts of what we do. Probably the most important part of PPE is the mask.
I mean, to me, thinking back, it was incredible how quickly we flipped from being completely unprotected, touching everyone, to society sort of taking a pariah view of HIV, and then all of a sudden people wouldn't go near or touch HIV patients. I mean, certainly in Britain, and you may remember this, but Princess Di, who led a sort of somewhat flawed life, she did one rather wonderful thing. She went to my hospital, the Middlesex Hospital, in the mid-1980s, to open a new HIV center, and she sat down on the beds of all the patients, and she held their hands, and she did it in front of the world, without gloves, in front of the world's media, and it sort of challenged the notion that HIV could be spread by touch. I mean, it was an incredibly moving moment. And it also shows the importance of leadership. And as you've rightly said, the analogy here might be mask wearing during COVID. So public figures send a message, or they don't send a message, or they mix a message. It's their choice. But it was a great moment of leadership. I mean, Daphne, just thinking back to the early days of the epidemic, are there any sort of standout moments for you?
Well, I started medical school in 1986. And I certainly recall the same feelings that Dr. Volberding is expressing of fear and uncertainty. And the loadedness of some of the decisions we had to make. So I remember distinctly, in fact, some of our classes in medical school just discussing the idea of whether we should or shouldn't wear gloves, because the wearing gloves was thought to be a way that we separate ourselves and we send a message to our patients that they are unclean or such. And in fact, many people would just wear gloves if the patient was gay, or and we were very conscientious about not wearing gloves. In fact, I don't know, Paul, if you have any recollection about of these kind of messages, but that we shouldn't wear gloves because the art of touch is so important. And we didn't wear gloves examining our other patients. Why would we wear gloves examining our AIDS patients, or sometimes by extension then our gay patients? Yeah. So, or our patients who were IV drug users. And so the wearing of gloves carried the loaded stigmatization that we were very much tried to stay away from. On the other hand, we were all frightened. Even in the 80s, when I was rotating as a medical student, we didn't really understand how AIDS was transmitted. And I remember being uncertain about whether it could or couldn't be transmitted by saliva, or through if something splashed into my eye, or if I had an open cut. Well, how open did the cut have to be? We all have hangnails. Was that a problem? And in 1988, and then 89, I was pregnant with my first child, and being on the wards, then pregnant was, as Paul expressed, very disconcerting, especially with the uncertainty. And of course, as a young physician in San Francisco, it was very important to me to be sensitive to my patient population and not to be insensitive, stigmatized, blaming. There was just as there is now, the disease was then, as it is now, politicized. And there was much of, and I hate to say it, and it makes me crazy, made me crazy then, makes me crazy now, but the idea that they deserve it, that.
Yeah.
Do you remember that, Paul?
Yeah.
Like somehow they sinned and they deserve it. I mean, I venture to guess that there are people who walk around thinking that now, and however horrifying that is to us as medical professionals, we dealt with that. We dealt with that in the media, we read of it, and we heard of it. from people around the world. Just as now there's blame and it's politicized and in ways that are honestly so ugly and demoralizing. And yet for us, the task of rising above and doing right by each other and right by our patients, of course, comes first and foremost always. But I don't know, Paul, do you remember those?
Oh yeah, a couple things, especially when, after 85, when I knew that I wasn't infected, and seeing the fear in the public, which, as you say, continued on. I made a real point. I was in the press a lot, not as much as people are with COVID, where you get to know their rooms and their houses. But I was on TV quite a bit, and I made it a real point not to wear gloves and to touch patients, because I think, again, that sort of leadership and that sort of messaging was so key. With COVID, it strikes me that in addition to Asians being stigmatized by the Chinese virus, as we've heard it said, I'm afraid that people are saying, well, he died, but he was really old, and so there's this ageism that is creeping into this as well. And the fact that COVID really disproportionately affects Black and Brown communities, it's kind of, well, it's not me, and so I think it's just as HIV, I think COVID really finds the fault lines in our society, and shows us the disparities that we certainly are still experiencing. Certainly,
yeah. I mean, both of them began as diseases of the other. Yeah. So HIV was gays, and then it was hemophiliacs.
Yeah.
And then it was people who had blood, and progressively it became all of us. Although we should have known that. I mean, I was a sub-intern in West Africa in 1980 and 82, and there were young men and young women dying of this slim disease, they called it, a wasting disease, that in retrospect was obviously AIDS. Both genders. But it began in the West as a disease of the other. And I agree with you. It's the same with COVID. It was a disease of the Chinese. Then it was a disease of the elderly. And that was a disease of the Latino and African-American community. But not us.
Yeah. As though we're not all human. And,
yes. But it seems like those walls are coming down, just as they did with AIDS. At least I hope they are.
I hope so.
I do worry about that, Paul, and I wonder if I could ask you about that, because I know you've done so much work on policy, and do you feel that the in some ways, like you said, with the AIDS epidemic, it sort of became acceptable. Like the deaths were sort of like we can sort of, I mean, the major societal response to AIDS was so limited for so long. And do you feel that we're in a different way starting to do that with COVID-19 in this country? I feel like it's kind of like, well, 1,000 deaths a day, and but as long as our economy is going and everybody gets to go back to school. I mean it's a really difficult balance, right? How to mobilize the public conversation when you have these diseases that are so identified with specific groups that are separate.
Yeah, I don't have a clear sense, Sue, about what's going to be, where this is all going to take us. I worry about, the fact that the science has gotten so politicized, and in a way that is worse than, in the HIV epidemic, the politicization was, discrimination against gay men, especially injection drug users. The fact that Ronald Reagan didn't mention the term AIDS until 1987, when it started in 1981. So things moved more slowly, but the discrimination was very real. I think here the issue is is the government going to support science or not? So far, there's not a lot of evidence that they really are. I'm really afraid that they're going to push a vaccine out in the population before it's proven to be safe and effective. And given that so many people are anti-vaxxers already, it'll just give them even more reason to distrust vaccinations, which, you know, the spillover effects of this could continue to be horrible. So I'm really worried.
I think that, building on what Paul said, whereas then too we couldn't really consistently follow our national leaders, I'll say that one of the reasons I was very intimidated to join as a panelist is because, in fact, Paul was one of the giants for me as a medical student. And even though, Paul, you were very young, I know, but still, in times of uncertainty, some leaders, regardless of experience and regardless of age, but probably because of conviction and dedication and, you know, charisma and passion, and end up leading us. And those are the people that we as 22-year-old fresh out of college followed. So when I was an intern, then pregnant with my second, I interned at a hospital where the vast majority of the patients were gay men with AIDS, and it was a rotating internship. So when I was on my surgery rotation, we would just get called in to scrub in with the attending because there were no surgical residents at this hospital. So as interns, we would scrub in, and I remember it was relatively commonplace that an AIDS patient would come in and would need an emergency appendectomy, and we'd go in. I remember all the interns whispering, "Oh, don't scrub in with this attending. You know, so many, you're going to get a needle stick. You're going to get a needle stick." It was such a common thing. The whisperings, "Don't scrub in. Don't scrub in. You'll get." I remember 4 a.m. being pregnant, and the terror of, should I somehow try to get out of scrubbing in? And of course I didn't, but I can still recall the visceral fear of it. And it's actually people like Paul, and exactly as Paul described, Paul going on the local, we didn't have internet, but we watched the local news and we read the papers, and seeing people like Paul, kind of our local passionate, devoted leaders, dedicated to the community with AIDS, and doing so open-heartedly, that I think drove us to also open-heartedly give of ourselves to the community. And the other thing I was going to raise, Paul, is that, you know, this is a long time ago already, and I don't remember many details, but one thing I remember is just how, and I suspect this is true for many of the trainees on the podcast, that it was very often that I found myself going, and I don't remember what it was called. I think it was called Coming Home, but there were many hospice, basically Victorians in the Castro section of San Francisco would become hospice units, and each room would have 1 or 2 patients, and the entire house would be, all its floors would be AIDS patients. And I remember, as my patients would get discharged and go into hospice, in fact, the way I recall following and being there for my patients very often was by going to the hospice units and after my day either in medical school or internship or residency, to be with them as they, you know, struggled for their lives, just to be present. So many of them had been, be they IV drug users or gay men for the most part. So many of them were so disenfranchised and cut off from their families and support resources. And it was on us as medical professions so often to step in, and really brought our community so close. I remember my then co-workers and joining me sometimes. Do you have those experiences and recollections?
Boy, many. A couple things. First of all, the fear in surgery was a real huge issue at San Francisco General Hospital. I don't know if you remember the orthopedic surgeon Lorraine Day.
Oh, of course.
Was just personally terrified of catching AIDS in the course of operating, and it got to be a big ethical issue because she insisted on kind of layer after layer of PPE, which we thought was to the point where it really was creating that distance, as you mentioned, between the caregiver and the patient, but also the sense that people that looked like they might be at risk for AIDS, i.e. gay men or injection drug users, were not being offered surgical interventions when they were actually indicated. And so this idea of what is your professional responsibility, and is it, even if you're afraid, physicians have always been at risk. That's part of our history. And to let that affect your judgment about patient care was seen as appropriately as a horrible thing.
I want to address. I'm so sorry, Paul.
No, go ahead, Tony. Yeah.
I just wanted to address something else that Daphne brought up, because I think it's very important. She was pointing out how you, as a young attending, were sort of leading the fight, and that was very evident in Britain as well. In fact, senior physicians and junior physicians knew the same amount about AIDS. Nothing. Having grey hair didn't make you any wiser.
Well, and another really important part of that, Tony, is that I was critical of the older physicians that didn't get involved in AIDS care, but in retrospect, they had a full plate already. They were already busy. They were doing good stuff for their patients, and it was the young guys, young women, because a lot of the early leaders were women physicians, starting our careers without a lot of other things actually to do. And we were the ones that stepped up. There was a definite cohort effect. A lot of the early HIV clinicians around the world were all about the same age.
It was a specialty that was built on 30-something. It's really it was a remarkable leveler.
It's so interesting to me to hear you talking about that and describing that, Paul, because I don't know if you've been keeping up with UCSF, but the same thing happened with COVID. And I can say, as a relatively senior attending, I'm much older than I look. It was a cohort of relatively young, many female, pulmonologists and internal medicine doctors who stepped up, who really were sort of early in their careers and really shone during those early days of the COVID crisis here. And, it's an interesting thing because I still remember, I can't remember who said it, but one of the leaders at UCSF during one of our town halls actually said, the people you're seeing leading this right now are going to be the leaders in medicine in 10 years. Because it's in these times of crisis that, people like that step up. And I have to say, I was afraid. So we didn't have any PP at UCSF. I think we had a 2-week supply at one point when we were really low, and we were trying to save it for the ORs. And they were asking us, to refrain from PPE. And I do a lot of aerosolizing procedures in head and neck. And it was frankly scary, but I kept going. And I took a lot of strength from these really young people because I knew that they probably had children or might be pregnant. And, yet there they were, leading the policy establishment and the front line for COVID. And so very interesting parallel to me.
Sue, as a leader now, I have to say it was one of the most disconcerting experiences of my life, because here I'm trying to do right by everybody, keeping our colleagues, our trainees, our therapists, our nurses, everybody at the front line, our young faculty safe, while also trying to do right by our patients. And we're physicians, we're healers. And yet the information we had was constantly evolving. And I think now with horror of, specific instructions that we gave not to wear masks.
To the therapists. I mean, our therapists, And I even still remember, Daphne, I'm ashamed to admit that we actually had a faculty meeting where I said, given the shortage of PPE in this country and at our institution, and, I had just been on a call with the surgeons who were terrified, and the bronchoscopy people and all of that. I mean, my friends who were surgeons were literally terrified to go in and do these head and neck and chest operations. And I actually said, I'm not going to wear PPE because, I think it's important that I set an example that we're preserving this for the OR so that we don't delay patients. And I think back on that, I mean, it would have been a lot easier if we'd had all the PPE in the world.
Yeah. That's awful.
Every night thinking about those early weeks when the guidelines constantly changed. And I just remember I recall Dr. Martin and our vice chair for clinical operations, and I talking about one Sunday that the weight on our shoulders just felt like it was going to just drag me into the ground. And I think one thing that I reflected on, and I don't know if the rest of you feel this way, is that being transparent with what we didn't know was incredibly important.
Super important.
Being humble about not knowing everything.
Yes.
And humble and transparent were two things that were constantly, like literally every minute of every hour, at the forefront of my mind, because things evolved by the minute, by the hour, and guidelines changed, and which component of PPE we were lacking that day differed, whether it was a mask, whether it was a gown, whether it was N95s, they evolved. And kind of the fear felt very familiar to the fear I remember feeling as a medical student and as a trainee.
One of the other important things, I think, is that what we learned in HIV, I think, is true here as well, that you shouldn't pretend that you know something if you don't. You should admit that you're making your best decision and that it might change tomorrow. And it doesn't mean that you were wrong today. It doesn't mean you were lying today. It means you're open to more information and you're trying your best to keep up with it. And if we can learn to do that, and I made that point in my editorial as well, I think that that's a really important part of leadership. And I think people would rather not be, falsely reassured. If then you have to go back and say, well, actually, that was false. So I think these are really important lessons. Yeah.
Yeah, I think the transparency for me, honestly, is what kept me believing in my institution. And it's why I forgive them for all the minor mishaps we had, because they, at my institution, they did a really good job of being transparent and admitting that there were huge gaps in knowledge the whole way along, and yet expressing concern. And maybe that was all BS, but it worked. I forgive them. I still, I felt so loyal to the institution. I actually think that, they just did a beautiful job managing. I have a question, because I know we're, I did have a specific question for you and Paul, Daphne. So Paul was an oncologist, and he got dragged into virology and became a virologist. And I would be interested in hearing about that evolution from you, Paul, because it is just such an interesting way that your career evolved. And Daphne, you were fascinated by the virus apparently, but escaped, and you stayed an oncologist. So maybe we could talk a little bit about that. It's interesting to me because we have some young scientists who talked to me, and a couple of them participated in some of the articles in the special issue. And it really feels like virology may become something very, very important in the future. So I'm curious about your personal perspectives, and I'm also curious, Paul and Daphne, how do you see virology? Is that going to be this century's defining illness?
Well, I'm biased, but yes, I'd say it is.
Yeah, you are kind of biased.
actually, it's
your foundation has a lot to do.
Yeah, it's a long story, and I won't do it. But I fell in love with viruses when I was in college. I worked in virus research labs at University of Chicago as an undergraduate, and I really went into medicine planning to work in virology labs, and I was interested in retroviruses at the time, when I was a med student in Minnesota. And at the time, that group of viruses, later HIV was one of them, but not at the time, but those viruses were thought to be probably common causes of cancer in humans. And so people that studied retroviruses tended to be in the field of oncology. And so I really went into oncology because of viruses, and worked in a virology lab here at UCSF. That's why I came here, really. And then along the way, I actually decided that I kind of liked medicine, and actually fell in love with clinical oncology. And so when I left the lab, I left the lab in '81 to take a clinical job. I was offered a chance to start a division at the General, right out of my fellowship, which just never happens. So I went from a retrovirus lab to a retrovirus epidemic, and never turned out to be a very successful oncologist because I got so fascinated by HIV, and that's, and I'm not an ID guy, and so I tell people, don't ask me about pneumonia because I only know one infection. And don't ask me about cancer.
Well, it's an important one.
Yeah, no,
I mean, to get back to this question of trainees, I mean, Daphne, did HIV change your training? I mean, I remember the floors being full of patients with weird lymphomas and Kaposi sarcoma. I wasn't seeing much breast, prostate, and lung in those days. Was that the same for you?
Yeah, I would say it changed me as a physician in two ways, and it kind of defined who I was. I'll start with the deeper way in which, I was married to a man with, by the end of my residency, 3 children in a very, very traditional marriage. And yet those with AIDS were very different than me at face value. And yet they weren't. And it really taught me that medicine in so many ways, not in all ways, of course, which we can touch upon in terms of disenfranchised, marginalized, underserved communities, but in many ways, it's the great equalizer. And it made me a much more empathetic and connected physician. I think the many evenings that after work I would go to hospice and sit at the bedside with one of my patients, and then basically walk through the house, through the Victorian, and just sit with the other AIDS patients. The very first patient I ever pronounced, I got called out of outpatient clinic to pronounce. I remember not exactly knowing how I was supposed to pronounce somebody dead. So I did what I thought was the right thing and tried to hark back to my medical school days. I was very early in my internship, I think. And soon I realized that this man's lover had been excluded from the room by parents who wouldn't allow the lover the partner to come be with a dying patient. And yet the parents themselves wouldn't come either because
we saw that all of the time, Daphne. I'm fascinated.
All the time.
Yeah.
And I remember trying so hard not to cry. And I remember even walking out of the room, just thinking, just hold it together till you turn around and walk out. Hold it. Just the depth of sadness and pain and loneliness. Didn't matter who you were, what you were. It was so unbearable and deep. When something like that touches you, it doesn't matter who you are, where you came from. Your heart just goes out to anybody suffering. It made me a much more, I think, empathetic and open and less judgmental physician and person, I think, as a whole. Made me a much better mother, too, and partner. And so it just definitely changed who I was as a physician and probably who I am now. And then practically speaking, I did stick with radiation oncology.
Yay. Good for us.
But so much of what we did was AIDS, but honestly, it was very it's where I learned so much of my practical radiation oncology, which I think is now what so many of our trainees actually learn on a palliative care service. How you actually deal with a patient who's hurting, who's in pain. When you have Kaposi's sarcoma of the sole of the foot, what energy electrons do you use? How do you choose? I mean, that just very bread and butter practical things that you don't always learn from, an IMRT or a VMAT prostate field, right? Where it's much more you read from a book and you look at a contouring atlas, or so very practical medicine that we learned as part of the AIDS crisis, and whether it was CNS lymphoma or ocular diseases, many other malignancies that our patients got, benign diseases that they got, such as Kaposi's sarcoma. Just learned a lot of very bread and butter, being practical and thoughtful, putting the whole patient's well-being together. And the last thing I'll say is that it also was a very interesting time to be at the cutting edge. And I'll remind Paul of this. I'm certain, I know Paul remembers this patient, but the very first patient who was going to have a transplant with a baboon marrow, because the thinking was that the baboon bone marrow was more resistant to HIV. And I remember being a first-year resident and being on call, coming in at 5 a.m. to because we were the one to give the total body radiation in preparation for the transplant, and of course discussing doing the consult, and then discussing the pros and cons and the risks and benefits and alternatives with the patient was so complex, and one had to be so sensitive to the entirety of the person, not just the disease. And I'm pretty sure he came in with his lover, actually, if I recall. I can't be certain of that, but anyway, being kind of at the cutting edge, and in some ways it was a little crazy in quotes. On the other hand, certainly trying things that were outside the box to try to do better by our patients and offer them potential cures was definitely at the forefront of our minds. So I know, Paul, that you'll remember this case.
Vividly. Jeff was his name. And, it seemed kind of bizarre at the time, but actually, a couple people now in the world are cured by really a very similar procedure. The people that have had BMTs for leukemia usually, who are also HIV infected, and they happen to get bone marrow from somebody who is naturally resistant to HIV infection. There's a small fraction of people like that. And so it's really the same thing. You're giving a marrow that you think is resistant to the infection, and if it takes over, then maybe it'll get rid of HIV, and it has in a couple cases. So that was an amazing story that we kind of were almost embarrassed about, and didn't too much talk or write about it at the time.
But the newspapers did.
Yeah, they did.
So I see Brian Kavanaugh's just rejoined us, so our time is coming.
Oh, well, Daphne, I wanted to echo something, which is that I think, if we're talking about formative experiences, because, for me, COVID is going to be my formative experience, a little bit different from the three of you, I think. And I think the saddest thing, as you were alluding to, is my patients who are not COVID infected, but as a consequence of the social distancing that's resulted, have been, essentially deprived of family contact because they're in a SNF. I can tell you I've had numerous experiences. Some of them were palliative cases where the patient was very ill and was either in the hospital or in the SNF and, had not seen their family member. I remember really vividly, we had one really elderly gentleman that I needed to palliate his leg, who had been a patient of mine before. So he came back to me and he, I went in there to do the consent before the sim, and he just broke down and cried for 40 minutes. And because he had not seen his family in almost 2.5 weeks, and he knew he was going to die. And I think for me, that experience of seeing people suffer as a consequence of not controlling the virus has been really hard. Yeah.
Well, I personally would have some questions, but we also have a couple of questions.
Oh, yeah, let's do it.
From the audience, if I may. I'll go in reverse order just because the second one came up here, and it's from a colleague of yours at UCSF. I won't name her, but she is a palliative care nurse colleague of yours who is wondering, as we look for positives to come out of this experience, and I'm glad, Daphne, that you brought up some positives. I mean, it helped you personally, and it maybe helped the community of medicine to be and society to be more tolerant, and it maybe activated a very important political base, if you will, to do good things. And so we'd like to think those are positives. So is this a potential positive that might come out of this in the medical space? Do you think there's hope, I'll quote, for clinicians to understand that palliative care is not the same as hospice or end of life, and that primary palliative care is necessary for all clinicians to practice, because we do have to help people along this journey, which can be a chronic experience for them. And do you see any positives coming out of it in that direction?
I'll jump in because this is such a, is that okay, Paul?
Yeah.
Because this is actually something that I learned at UCSF and I think did come out of the AIDS. And now, I mean, such a beautiful question. And I was just talking to one of my fabulous residents in the past few weeks. And the term that many of us use when we don't want, when we're not going to offer radiation, we so often say, well, should we do nothing? And I think that the intent is that we're not going to intervene with chemotherapy or radiation. But that what I learned at UCSF, and I know others have learned, and the beauty of the question highlights, is that we never do nothing. Just sitting with our patient and holding their hand is as important as anything that we do. So I've discussed with the residents, and I think so often of myself, of never using the language of we're not going to do anything, but rather that, okay, we're not going to intervene with radiation, but we're always there with palliative care in its many, many, many forms. Sometimes it's touch, presence, comfort, whatever it is. Paul, I know you have a lot to say.
Well, yeah, just absolutely. And again, it's a great question. And I'm actually going to be on a webinar in a couple of weeks about palliative care and HIV and COVID. But the first years of the AIDS epidemic, all we did was palliative care. And you're absolutely right. So it's like everything we did, whether it was kind of helping the partners be part of the presence in the inpatient unit, and connecting people to volunteers who could help them, or using radiation therapy for the people with capaces, with lymphedema that was excruciatingly painful. It wasn't going to cure their AIDS, but we never would say we're not going to do anything. You're totally right. We did a lot. We worked hard in those years to make life a little bit better.
It's the first time I'd ever seen team-based care.
Yeah.
We didn't see it anywhere else in the hospital, but the AIDS patients did get it. It was a remarkable thing.
Absolutely, yeah.
So if I could build on that, this notion of how important it is to have palliative care and how important it is the human touch. Parag Savi's comment leading up to this, which I was saving as the second question for a certain reason, is a comment on how he and a lot of us as physicians miss the touch, the human touch, the personal touch. We are separated from patients physically by important barriers, PPEs. How do you see that? Do you see that as a big part of maybe the toll it's taking on physicians? I mean, it takes a toll on patients, right? And what if that is one of the key stressors? Perhaps you might add to that. Do you see some other parallels with how physicians are stressed now as opposed and how they were stressed before?
Let me just put in a plug for a movie. I happen to be in it, but the star of the movie, the stars of the movie were the nurses on Ward 5B. That was the AIDS inpatient ward at SFGH. And it's a great movie. It's a regular full-length documentary. It's on Netflix, I'm sure by now.
It is.
But it's a lot of it is about touch.
What's the name of the movie, Paul?
5B.
It's called just 5B as in boy. That's the ward. The movie is just called 5B, and you really should see it. And if you're interested in palliative care or the power of touch, that's a big part of it. And if you do watch it, stay with it all the way, even after the credits, because there's a little end piece about Lorraine Day that's really worth the ticket. But yeah, no, it's a good question.
I think even the question reflects so beautifully on the questioner, because the Parag, I think because of the wonderful physician that he is, I think if I can put words in his mouth because he can't speak right now, is that he misses the power of touch. And I have to say there have been a couple times in the past 3 months that I know it was wrong, but I hugged my patient. And I still kick myself, and I think everything was fine, but still I was like, oh my God, how inappropriate, what a terrible example I set. But sometimes you're so used to just that hug, that comfort, that touch that connects you with the patient. And I knew for the most part it was wrong before I did it, and then I really knew it was wrong after I reflected on it. But that power to connect with the patient can be so overcoming sometimes. So I completely agree that it's extraordinarily difficult to practice medicine without the power of touch now. And Parag, I think that just reflects what a wonderful physician you are.
Well, it's hard to be a human without touch. I've gone now 5 months I've touched my family, but that's it, which just totally strange, and not in a good way. Yeah.
I want to echo the sentiment, Paul, about the value of nurses, because what I've noticed, just speaking about my own service, is that we have some patients with tracheostomies or, other sort of aerosolizing risk as we've classified them. And, I set that policy up to protect our staff and myself and everyone else, about how they would be handled in the department. But it does have a distancing effect, and I noticed that those patients don't get close to anyone, right? And I've just been so grateful to a couple of our nurses who've gone in there and helped them suction and, taken care of their skin and touched them. And I really believe that might be the major form of interaction they get in our department. And it's so incredibly brave, the staff that do that.
Definitely the nurses and our therapists and our MAs and our
therapists, yes,
and our faculty. Those are on the front lines who, with such bravery and thoughtfulness and open-heartedness, just, follow their calling.
Can I ask a question to you, Paul, a somewhat factual one? I'm going to take host prerogative. Do you think that this condition of sort of these sanitary procedures that we're living in, do you think that is going to go back to normal? I know this is a huge speculation. Or do you think this is really part of the future and how medicine has changed a little bit for good?
Oh boy, yeah, you're right. I don't know. I'd say that we will never be blasé about the potential for another viral infection kind of popping up, and so I think it's changed us for forever. No question. And I think the value of masking is something that we sense that we're seeing it in other viral infections. So these old tools are going to be part of what we do, I think, for as far ahead as we can see.
And Paul, one final question from me. It's a very simple one with an impossible answer. Vaccine or therapeutics? What are we to hold out?
I'm more of a therapy guy.
I thought you might
because there hasn't been a vaccine for HIV, and we have great therapies. So I'm going to kind of hope that the bench scientists kind of come up with enough kind of targets to. I think the challenge of vaccine is it's not as bad as it is for HIV, but I think the hints that we're getting are that it's not going to be a perfect vaccine. It won't last forever, and given this whole political stuff that's out there of people against vaccines. And if we're going to rely on a vaccine, then we need to vaccinate a lot of people for it to have any kind of general herd effect, as they say. So I want a vaccine personally, but I almost think more that we're going to see a therapeutic. None of the ones yet, but there'll be some breakthroughs.
So first of all, I think I want to respect people's time, and I so thank everyone for participating. There was one more excellent question, which I'm going to acknowledge, but not let anybody try to answer because it would be the subject of its entirely own hour and a half of discussion. And Gavin Jones is asking about the pros, cons, hinting at what's the medical ethics of how we sometimes have to ration or carefully distribute other care, cancer care, in this sort of time. And I don't want to be ignoring that question, but it's such a big and difficult and challenging question. I think it's almost too big for us to answer in a short soundbite or two, but I do appreciate the question there. But
sounds like your next webinar.
Exactly. There you go. There you go. We're set. So,
I mean, I think if we're talking about stress on providers, and how that changed my generation, I'm a little old to claim that this is my generation, but I'm going to do it anyway. I think that really was, we all think about sort of cost effectiveness and, being responsible stewards of the healthcare system. But I think that was the first time that so many of us had to say, like, okay, when it really comes down to it and you only have X resources and you have to choose, how do you do that? I just don't think Americans have confronted that before like this. And that for me was also very painful. And I can tell you I was incredibly stressed out. I had to help our department with working through some of those questions. I was sort of one of the leads on that. And it was so incredibly challenging that even my computer programmer who was helping me work through this got depressed. That was hard.
But thanks for inviting me to be here today. It was really a great discussion.
Thanks so much. And thanks much, Anthony, for coming around. And this was a fun little thing. And we'll see how it looks when we look at the recordings, and we'll put them up online and put them out there as a podcast and see how we can do better next time. But I thought this was really good because you guys all gave such soulful and personal observations and shared such really good stories that I really thought it was terrific. So thanks again, all of you.
Thanks.
Honored to have spent the evening with you.
Yep.
Brian, I want to thank you for hosting the RedJournal at VVPN, and I hope this is the beginning of a wonderful collaboration. You've developed such an incredible platform, and the RedJournal is always trying to innovate and educate. So we're excited about this partnership.
Have fun in Miami.
Yeah, show that video. It's going to be good, right. Paul. Watch the video.
Bye-bye.
All right.
Goodbye, everyone.
Bye, everyone.
Thank you.
What a pleasure and an honor.